we removed the implant and then performed a fixation with dual plating, sir.
There is OFA component also is there? OFA?
Yes, sir. OPA component is also the medial OPA.
So what percentage of HOFAs are medial HOFA, lateral HOFA? What is the percentage of difference, medial and lateral? Which HOFAs are more common, lateral or medial?
Lateral.
Lateral HOFAs are 85% are lateral, only 10 to 15% are medial. Less than 1 to 2% are bicondylar HOFA. We have got bicondylar HOFA with a floating knee. It's also gold medal presentation, yes. So why do you prefer a dual plating here?
So to reduce the deformity and to negotiate adductor deformity, sir. Adductor muscles.
Is it going for delayed union or non-union?
It's there is a attempted callus formation is there, sir, but due to weight bearing, it has deformed.
Okay.
It's just 6 weeks to say any delayed or non.
Right, yes, go ahead.
Yes, sir, but yes, sir. Yes. But the direction is proper, sir.
"50-year-old male with closed middle third, distal third junction, shaft fracture of radius, and distal third shaft fracture of ulna of right forearm, sir. We have done ORIF with plating for radius and ulna, sir.
Which is first, radius or
Radius.
left? Radius you have done for. Which bone is opened first, radius or ulna?
Radius.
Why? Is there any criteria, no criteria? So first of all, you have to open the radius and you also open the ulna. See that there is good amount of fracture reduction, retention. So everything is possible. Then only you have to fix the radius. If it is unable to fix the radius, because radius is somewhat curved bone, ulna also curved bone, but is more curved. Radius is more curved to accommodate the articular surfaces. So in those cases, you have to do both the things. You have to see anatomical reduction, retention is possible or not. If it is not possible, you have to shorten the ulna. Because ulna is a more of straight bone and it is a axial bone. Axial bone means over the ulna, the radius will rotate. The third joint works there. What is the third joint? Interosseous joint. That works well. So that is the reason. So by all practical purposes, the both bone forearm fracture in adults are to be considered and treated as intra-articular fracture. What do you mean by intra-articular fracture? Anatomical reduction, articular congruity, and no angulation, no displacement, no rotation. Yes, go ahead.
66 years old female with 6 weeks old intertrochanteric fracture of left femur, sir. We have done CRIF with long PFN for left femur.
You have used the washers.
Why? With washers.
Why washers? Is there a lot of comminution or the bone is osteoporotic? What are the advantages of washers?
Comminution was there, sir.
Go back. Yeah, what is the age?
66.
So what type of fracture is this? What type of fracture?
Comminuted, sir, type 2.
Is a Boyd Griffin type 1, type 2, type 3, type 4? Osteoporotic.
Yes, sir.
Osteoporotic. So what are the advantages of washers? Number 1, it prevents proximal migration. Yes. Number 2, it gives more of stability. Number 3, removal also very easy with the washers. Okay, right. Better anatomical reduction. So to some degree of reduction also will possible with the washers. And it prevents the proximal migration. That is more important. Go back. Go back. So it goes into proximal migration. So you have to follow the case. Delayed the total weight bearing.
Yes.
Yes, sir.
26 years old male with 5 years old post-op follow-up case of supracondylar fracture of right femur with implant in situ. We have done implant removals. 40 years old female with closed middle third, distal third junction shaft fracture of left femur, sir. Winquist and Hansen classification type 4, sir. We have done ORIF with plating with 12-hole LCP, sir.
So what is the criteria? So how to judge what length of LCP plate is needed depending upon the fracture pattern? Yes, Vinay.
3 times the length of fracture.
Huh?
3 times the length of fracture.
Mike, use the mic.
3 times the length of fracture.
No. Yes, go ahead. No. So this is different, this is different. Yes. Isaruddin. So the fractures can be a transverse fracture, or it can be a long oblique fracture, or it can be a spiral fracture. So depending upon the fracture length, suppose the transverse fracture is there, the plate should be 3 to 4 times longer in case of transverse fracture. In case of spiral fracture, oblique fracture, the length of the plate should be 8 to 12 times. So that's why you're using the long plate. Earlier you have used a short plate. You have know some of the cases. So that is important. So it depends on the fracture configuration to the length of the plate. What is the basic principles of ACP, LCP? The working length of the plate is inversely proportional to the length of the plate. They act both internally as external fixator. They are called as bridge plate. They are called as bridge plate. Yes, that's all important. So here it is a rigid construct or a stable construct. What type of construct is this? Is a rigid construct or a stable construct?
Stable construct.
It is a rigid construct. When you talk about rigid construct, construct in relation to interlocking screws with the plate, that is the rigid construct. When you're talking about the fracture fixation, that is called as a stable fixation. If you go for a rigid fixation, fracture fixation, what is the problem? A rigid fixation of the fracture fragments. What is the problem? Non-union. That is also, that's why in some of the cases we have shown the dual plate. If you don't treat it, if it's not a good stable fixation, only rigid construct, it fails. So where there is a need of a dual plating for better fracture union and to prevent non-unions. Yes, go ahead. James Rizan ante kada. Basic principles ayi madalse exam lo ade edutadu. 3 times inda deniki 3 times Ramudu, Bhimudu, Krishnudu. Transverse fracture, oblique fracture anni okatena. Oreni చదివేస్తే
So this is the case done in unit 2, sir. 55 years old intertrochanteric fracture of right femurs, type 2, right sides. Verdum closed reduction with PFN for right femurs.
So this is the 55 years. 60 to 65.
In Aragastri, 55.
See, this is the problem. Females more than 65 years and all those, there is anterolateral bowing. So that should be very, very careful. Otherwise, there is a stress riser effect and you can go for a hardware problems, or there may be splintering, or there may be breaking of the lateral cortex. This is a problem. So you should be careful. So in those cases, you have to negotiate. If necessary, better to go with a long nail. So because long nail will have more of working length. So when there is working length is more, the fracture configuration is better, the functional outcome results are better. So that is a disadvantage, especially in females. You should be very, very careful. Even males also, more than 65 years females, more than 75 years males, the anterolateral bowing. So that negotiation is very, very important. Yes, sir, go ahead.
Good morning, sir. These are the cases done in Unit 1. A 44 years old male with 1 week old closed proximal third shaft fracture of right tibia with no DNVD. This is the pre-op clinical picture.
This is a old fracture, huh?
Yes, distal one is old fractures.
How many years
5
old?
years ago. He underwent native treatment.
What is the native treatment?
Yes.
Yeah.
So we did open reduction and internal fixation with plating for right tibia.
Go back. So isolated fracture or fibula also fracture?
Isolated fractures.
Isn't it?
That is Old
Old, sir.
ones.
That is old one.
5 years ago.
Okay, sir, go ahead.
71 years old male with intertrochanteric fracture of right femur. We did closed reduction internal fixation with PFN and washers.
Washers. You are also using the washers. Sometimes the washer cannot accommodate. Sometimes he'll accommodate. That is also important. Yes, sir. Go ahead, sir.
46 years male with intertrochanteric fracture of left femur with subtrochanteric extinction. It's Boyden Griffin's type 4, sir. We have done open reduction internal fixation with long PFN and circlage wise for left femur, sir.
How many? 3?
3, sir.
3 circles, huh?
Yes.
Okay. See, there is a bowing. Follow the case. Okay, sir.
60 years old male with 6 months old anterior dislocation of right shoulder, sir.
What anterior is subcoracoid, subglenoid, subclavicular,
Subcoracoid.
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 Huh? Subcoracoid or subglenoid?
Subcoracoid, sir.
Subcoracoid. Yes, sir. Yes, sir. Go ahead.
We have done MRI as well, which shows there is an Bankart's and Hill-Sachs lesion as well, sir.
So this is the first episode, second episode, third episode, fourth episode,
This is third episode, sir,
third episode.
in whole 6 months.
So what is the ideal criteria to call it as a recurrent dislocation of shoulder joint?
3 episodes in 1 month.
Huh?
More than 3 episodes in 1 month and more than 5 episodes in
1 month.
More than 2 episodes in a year, sir.
Huh?
More than 2 episodes in a year, sir.
Year. Yes. Any better answer? Any better answer? When do you plan for? When do you say it is a case of recurrent dislocation of the shoulder joint? When do you plan for surgical management? You have to plan it. All cases of recurrent dislocation cannot be managed with closed methods, non-op methods. Sometimes again they go for recurrence. What is FEDS? FEDS. Frequency, etiology, and duration. Yes, severity. So Bankart lesion and Hill-Sachs lesions. You are looking to both the things. So the episode should be calculated per year, not per month. Some people say per week, per 1 month. Should be calculated per year. Any episodes, more than 3 episodes in a year, it's called as recurrent dislocation. The ideal indication for surgery in recurrent dislocation of shoulder joint is more than 3 and or more than 5. If the 5 is 100%. So even you do, you won't get a good results. So there are different letter jet procedures, Boycho procedures, so on and so forth. We have got some of the cases where you have done the Boycho procedures. We have got a given result. So you are only reduced it, no surgery. But you should be careful because it is having both Bankart and Hill-Sachs lesion. What is Bankart lesion?
anteroinferior glenoid labrum defects on repeated anterior shoulder dislocation.
So
there will be
glenoid labrum, avulsion. A Hill-Sachs, posterior lateral
posterior
defect.
lateral humeral head defect.
Femoral, posterior lateral femoral. So both are there. So these are 3 episodes in a month or year in your case.
In our case, 3 episodes in 6
Remove
months.
your mask, amma. Use the mic.
3 episodes in 6 months, sir.
6 months. 3 episodes in 6
6
months.
months.
Right side or left side?
Right side, sir.
What is the age of the patient?
60 years.
60. So diabetic, non-diabetic,
Not-
rheumatoid arthritis, any other problems?
No coma.
No comars. Yes, go ahead. Are you fall from a bed, fall from a staircase, any?
He was lifting heavy jute bag over his shoulders. Then he noticed. No. Yes. Six months.
3 episodes in 6 months. 3 months. So you want to give the highlight of Hillsacks and Bankat, both are there. Okay, go ahead. Sleep dislocations.
We have done open reduction and internal fixation with two K wires. Yes, it was. No.
Native treatment, sir. Went for native treatment, sir. Yes.
And K-wire fixation is not a stable fixation. It is only biological. It comes out, and there is definitely at 60 years. There is laxity, and it's the recurrent episodes. So you should be very careful. No? Again, she will go for one more or two more episodes. You should follow the case very carefully. So these cases, how to prevent the recurrent dislocation? How to prevent the recurrent? Already 3 episodes are over in 6 months, but you want to prevent the further episodes, recurrences. How to prevent the further recurrences and further episodes? Yes, Sushma Sri. How? What advice do you want to give? You are the treating surgeon. What advices to give to the patient? Hospital for joint diseases and rehabilitation protocol. 10 marks question. Hospital for joint diseases and rehabilitation. What do you mean by joint disease? It is not a joint disease. It is a fracture disease. So that's why they use the word hospital for joint disease. Joint disease ledu. Fracture disease is there. What are the components of fracture disease, Sushma Sri?
Stiffness, wasting of
Joint
muscle,
stiffness, wasting,
and periarticular
deformity, loss of function, and lastly,
periart
regional or
osteoporosis.
localized osteoporosis. These are the components. So how to prevent?
By preventing overhead abduction.
Overhead abduction, excessive activities, which activities stimulate the dislocation should be avoided, especially overhead activities. She is 60 years female, no?
Males.
Male, 60 years male. Name of the patient?
Rajanna. Rajanna, sir.
Rajanna, 60 years. Right side dominant. So be careful, right? That is important. So dominant hand is also dominant shoulder, everything. Dominant side is also very important. Otherwise, he has to go for a recurrent dislocation, surgical management. Yes.
We were planning to remove K-wire after 3 weeks.
Deltavectoral approach.
You have given a universal shoulder joint immobilizer.
Yes, sir.
Photograph is that is also very important. So after treatment, because it's K-wires are biological fixation.
We use
With no movement, it comes out.
71 years female with fracture neck of left femur, sir. It's subcapital type of fractures. We have done bipolar cemented hemiarthroplasty for the left hip, sir. (55 years male with intertrochanteric fracture of left femur, sir, with subtrochanteric extension. Boddington Griffin's type 4, sir. We have done open reduction internal fixation with long PFN and circlage wise for the left femur, sir. 24 years male with 3 years post-op.
Here no washers.
No washes, but circlage were used.
Circlage were, yes. Go ahead, sir.
24 years male with 3 years post-op case of sharp fracture of right femur with implant in situ, sir. We have done implant removal. 28 years male with closed middle third shaft fracture of right tibia and proximal third shaft fracture of fibula, sir, of left legs with no distal neurovascular deficit, sir. We have done closed reduction internal fixation with ILN for left tibia, sir.
Previous case, 24-year-old, why PFN was done for that case?
He had a history of trauma 3 years.
At 21 it was surgery was done, sir.
He had
At
a
the age of
proximal
21 it was
femur
surgery was
shaft
done,
There
sir.
was a neck fracture also then. I see neck with shaft fracture or only
No,
neck?
sir, only proximal third of the. It was just subtrochanteric, sir. It was.
Somebody collecting these cases, there are 3 cases of subtrochanteric fractures this week.
Yes.
Surplus wearing them. Good topic for thesis. Who's collecting? Tell I am collecting or Vinay is collecting or who's collecting?
No, sir.
We will collect.
We have done closed reduction internal fixation with ILN for left tibia, sir.
Entry point is ideal. Okay.
It is slightly lateral, sir.
Entry point is ideal. Center, AP lateral.
And the leg was externally rotated, sir. It was
Okay. Fibula is intact here. Fibula is intact.
proximal third.
That's here.
Yes.
Okay, right. Go, sir.
11 years old male with closed middle third shaft fracture of left tibia and proximal fibula fracture of left leg, sir. We have done closed reduction internal fixation with tens for tibias.
What is the age of the patient?
11 years.
Which tense is first, medial or lateral tense?
Lateral is applied.
You have taken lateral. Is it true? Which is better for tibial?
Medial.
Medial is better. For femur, lateral is better.
65 years male with closed middle third shaft fracture of left clavicle, sir. And there is puckering of the skin was present, sir, at the time of presentation. And in intra-op combination is present, sir. We have fixed with KYs, stabilized with KYs, sir. We have done open reduction internal fixation with plating for left clavicle, sir.
So 13 years male with 5 years old proximal third fracture of left femur with implant in situ and with discharging sinus. Is there the pus discharge? 5 years back, sir, at the age of 8 years.
So discharging sinus, when did it start?
Since 6 months, sir. On and off is there. So we have done implant removal and debridement, sir. Yes, sir.
So what do you think?
And
What was
sir.
the reason? Why it got infected so late? What was the reason?
In fact, actually, he is complaining of discharge from after 3 months of surgery, sir.
So it was chronic.
Yes.
Right. Okay.
Good morning, sir. Today my topic for journal is outcome of closed wedge varus derotation osteotomy with trochanteric epiphyseodysis in Perthes disease, sir. It was done in Kerala, sir, KIMS hospital. Introduction. Perthes is,
Whom did you ask advice regarding this one?
sir. I have asked KJ Reddy, sir. Jagdish, sir.
Okay, one.
Yes.
Last time only I mentioned what is the journal name, what is the impact factor, all that has to be mentioned. It's not a photo and whatever you are doing, first read the abstract so that we know what you are presenting.
Yes.
What journal is this? We don't know. You are telling Kerala means
Indian Journal of Orthopedics. It was done, sir.
Huh?
Indian Journal of Orthopedics.
so that is when was it published? Which
It was done in 2018, sir.
Where are they? Ramesh?
Yes.
Did you get it from internet?
No, sir. I have a full article from the internet. Sir.
If you know that only, we'll know about the value of the study that you're presenting. Is it some local low impact factor study or some high impact factor journal?
You have to get good review articles. Yeah, I told you, in general is okay, good, but COR, JBJS, these are authenticated, and you get a lot of information from them.
Okay.
You can hold these ones, but this is a single department, single surgeon, is it?
Yes. Sir.
Okay, go on.
Introduction. Perthes disease is a condition in which self-limiting avascular event affects the capital epiphysis of the femur with variable course. Most of the today therapeutic approaches are based on the concept of containment, sir.
And do you know why you present a general club? What
Uh,
is the intention of presenting a general club?
Today we have a Perthes case, sir. So
No, no, what is the aim of presenting a general club? Why do you want to do a general club? Anybody? Why do you want to do a general club?
outcome of the we know the outcome of the surgery, sir.
That's okay, that's paper. What is the intention, main intention? Why are you doing MS orthopedics? What is the reason? Why do you want to do MS?
I was interested to do, sir.
So you want to become a good orthopedic surgeon,
Yes, sir.
isn't it?
Yes, sir.
Similarly, why do you want to put a general club? What is the intention? Sushma? Any senior residents? Yeah. See, come, senior resident, come in the front. You should participate. Front seat should not be back. People come to the front. Even first years, come to the front. Yeah. You pass. Okay, keep updating. One. Then. Okay, that's updating. Anything else? What is the main intention? I just said to MS you're doing, become an orthopedic surgeon. So, presenting this one? Oh, new things. Always you learn. You newspaper also, you learn new things. Oh, outcomes, that's okay. But what is the main intention? Why journal clubs are introduced? What is the meaning of a journal club? I know you want information, you want to see the outcome, you want to practice. That's one aspect. What else? What is the main motive? I told you, did we discuss in the past?
So that you improve your research methodology so that we come out what are the limitations of the study, we can
Sit
get
down.
a new study out of it so that we can publish a better journal. Okay. That is why you have to critically analyze each journal that you are presenting.
Yeah. So it is your ability to analyze. Journal club is not the material. Material is not important. Material you can get it. Material also important, but that's not the aim. Journal club you present to analyze, criticize your ability to improve a journal club. So, like orthopedics,
Yes, sir.
you want to become a good orthopedic surgeon. So, journal club, you want to publish a paper. Understood?
Yes, sir.
That's whole idea is you want publication. How they published, whether any downfalls, anything you can improve, and how you can do it. That's whole idea. So it's not the material important. See, the old culture is gone. And next time, I think, ask me what we have to. Who is presenting next week, next Thursday? Nobody. Who's? Oh, it's okay. So just ask him to see me. So the whole idea of journal club is whether you have the ability to have a critic eye, criticizing the journal, starting from title. What is the title?
Outcome of closed wedge
Ah.
versus derotation.
So, do you think this title fits the article?
Yes.
Next one, what is it? Abstract.
Yes, sir.
Abstract. Abstract is whether abstract describes, because most of the time you read only abstract.
Yes.
And then if your abstract is interesting, you read the entire article. Okay, next one, what is it?
Introduction.
There is no introduction. There is nothing like introduction. Introduction is, you don't have to put an introduction in journal club. The introduction is what is the justification. Next one. Material methods. You have to criticize whether their material methods are appropriate, whether any pitfalls, anything you can improve. Next slide. What is the next heading?
Inclusion and exclusion criteria.
That's material methods. Within that, whether
Follow-up.
follow-up. Follow-up also you see whether it's what is the main thing in follow-up.
For how many months it should be
Yes,
followed.
duration is important.
To know the outcome of the condition.
Always outcome, only one word, isn't it? Outcome.
Yes.
Duration is important, and how many people are followed up. If many people are lost to follow up, if 80% of the people are followed up in the study, that's a good study. If they've done 100 cases, 50 people lost to follow up, that's not a good study. Next heading. Procedure. Okay, procedure anybody can do. Whether this procedure is validated procedure. You know what is validated?
Yes, sir.
What is validation?
The given data is true or not, sir.
See, if you don't know, you should not talk. If you know, then only you have to speak. Important, because if you feel that you know everything, you will not learn.
Yes.
What is validation? Nobody is looking at me. What is validation? Correct? How do you check? What is validation? That is a scientific term. Anybody? Sridhar?
Validity of the procedure is if the same procedure is done by another surgeon in another patient, it has to be reproducible.
Yeah. Validation is that procedure is done in the past and predictable outcomes have come. One surgeon may be doing a procedure, rare procedure, excellent results, but is not reproducible by others. And it's validated means is scientifically proven. There is scientific evidence to say this procedure works. That's called validation. For everything you validate scoring, validate procedure, validate material, everything is validated.
Yes.
Then only you have scientific publication. Okay. Next, what is the heading?
Post-operative classifications.
Because you
Follow-up.
focus more on theoretical part, which is already existing. Journal club is important what is there in the published, in that article. Because this is all not relevant. Your introduction is not relevant. This is not relevant. It can be there anywhere, isn't it? You're not learning anything new from this article. Next one. Because if they classify based on their study, that's relevant. Okay, what is this?
Most index.
Did they say or
They
previous
mentioned-
one?
No, sir. They have mentioned these classifications based on outcomes.
Okay, next one.
Results, sir.
Results, okay. Results you have to, how results were analyzed and whether they are true results or not. Okay, next one. What is the heading? Next heading.
Conclusions.
Discussion is not there.
Discussion.
Discussion is important part. You not mention about discussion. You missed out. Discussion is important because they have to justify. Discussion, introduction is not important. Discussion is important. Discussion, what they say, previous studies were done. Our studies, our procedure is as good as previous one. That is validation. Or anything, any pitfalls. We could not do this one. We could do this one. Their, what is that called? Their way of supporting their study.
Okay.
Conclusion? What is conclusion?
He had supported what he has done, and the outcome was appropriate or not.
Conclusion means what the message they can give from that study.
Yes.
You understood? Conclusion means conclusion of somebody, not somebody's study. Conclusion based, whether they concluded, conclusions were based on their own data or elsewhere.
Okay.
Okay, just tell the procedure about. So next one, whoever presenting should be able to analyze or criticize, say whatever. First, beginning, title. First of all, of course, as Sridhar said, you have to mention most important part in publication is where is the source, which year. If you're presenting 17th century data,
It was not.
we don't know. It's not relevant presently.
Yes.
So what is the journal? Based on journals also we can assess. To publish in this journal, there should be some genuine thing. There should be some level of standard. That also important. Okay. You don't worry about interaction.
Basic few important points
No.
I'll mention. Most of the today's therapeutic approaches are based on the concept of containment, sir, to keep that subluxated head into the acetabulum, sir. Subtrochanteric varus derotation osteotomy aims to decrease the neck shaft angle and anteversion of the proximal
Next
femur.
slide. Okay.
The clinical outcome was assessed by Cattrall postoperative classification, and radiological outcome was assessed by sphericity of the femur head after healing using Mohs index, sir. They have taken 88 patients, sir, and they have done retrospective and prospective, sir, study.
So go back. This is important. Material method, whether a retrospective or prospective study.
Yes, sir.
What is the advantage and disadvantage of both studies? Retrospective. You can't combine two together anyway. I mean, they've just it's an audit, isn't it? They're just observation. If they include both retrospective and prospective, means observational study.
Yes.
So it's not a scientific study. Retrospective means what is it? What is a retrospective study? I'm not just asking him, I'm asking everybody. If he's not able to answer means you're also not able to answer. Yeah, go on. Pratik.
The previous done surgeries were they taken as the study, sir.
No, what
Previous
is
done retrospective?
You're not understanding my question. What is retrospective study? Previous study is okay, but technical. Because we are in the journal club. Retrospective study means previous.
Past what the surgeries.
Whatever been existing in the department, they just collected the data.
Yes, sir.
Data is collected retrospectively, means
Yes, sir.
procedure is already done.
Yes, sir.
There is no protocol for those procedures. And nothing, just whoever is done without following any protocol, you just collecting the data. Okay. Prospective means?
After the study started, we will follow up the cases, sir.
No, what is prospective study?
Effect. Yes, sir.
Prospective means you start study
Yes.
and recruit patients from today. Once you finalize the protocols, finalize all the procedures. Prospective. So prospective study will have higher value.
Yes.
What is the next level study? What else you can do? So you said retrospective, prospective study. What else is there? About studies, trials or studies? You don't know. Okay, anybody? Other types of study? Vivek? Anybody?
Level of evidence you have, no? Case control, cohort, randomized control trials,
Meta-analysis is only publication, but studies have done. So next is prospective randomized study. Prospective randomized.
Yes.
Or can be prospective double blind, where you don't know which one had treatment.
Yes.
These things you should read. I think these are important for your nowadays publication. Unless you know all these things, without knowing this, you can't present a journal club, and you won't be able to analyze. Next time onwards. Okay, gone.
So that indicates the level of evidence. Retrospective level of evidence is 3.
Inclusion criteria: age group of 5 to 13 years, lateral pillar group B and C, containable hips, children in fragmentation stage, sir. Exclusion: bilateral hip involvement, age less than 5 years, age more than 13 years, sir. Follow-up 6 years and maximum of 26 years with mean follow-up of 12 years, sir. Mean age at presentation is around 7.9 plus or minus 2 years, sir. The mean time between diagnosis and surgery was 3 months, sir. Operative procedure: varus derotation femoral osteotomy was done using a lateral approach with a closing medial wedge osteotomy at level of subtrochanteric region, sir. The varus correction of 20 degrees was aimed. Depending on the degree of desired varus correction using fluoroscopy image guidance. Abduction of the extremity brings about the desired containment angle of the femoral head, sir. The degree of abduction is expressed by the angle formed by the shaft of the femur and a vertical line parallel to the midline of the pelvis, and this angle represents the desired wedge to be removed, sir.
Have they given any pictures? Schematic pictures?
Yes,
Yeah,
sir.
you should put this one.
Yes.
Okay.
It's a vertical line, and the desired angle is this one, sir.
Mm.
And the femoral shaft width at osteotomy site, sir.
Mm.
And the desired angulator change. For example, where there is a width of 25 mm and the desired angle is around 20 degrees, then 9 mm of the base should be removed, sir.
Mm.
The distal fragment were externally rotated about 20 degrees, and the fragments were fixed using a molded 6-hole dynamic compression plate, sir. Trochanteric apophysiodisis was done by drilling the apophysis and introducing the proximal-most screws across the physial plate. And apophysiodisis was done.
Mm.
No plastic immobilization was done, but weight bearing was denied until the osteotomy was united. The implants were removed after 12 to 18 months. At follow-up, all hips were evaluated clinically and radiologically. Cateral postoperative classification, sir. These were based on the radiological and hip motion, sir. Asymptomatic hip with full range of motion and with a round and well-contained femoral head is good, sir. Asymptomatic hip with slight restriction of movements, especially internal rotation with head round but broadened and not fully contained up to 1/5 of being uncovered, it is fair. A hip which was not free of symptoms with restriction of movements was classified as poor outcome. Mose index. Sphericity of the femoral head was evaluated using Mose index. According to the index, the results were classified as good if head is spherical on anteroposterior and lateral radiographs. Fair is if the head was not spherical but deviated less than 2 mm from the concentric circle is fair. Poor is more than 2 mm of the deviation is present. Central edge of angle of Weiberg's. Amount of hip subluxation was evaluated using central edge of Weiberg's. It is a vertical line that runs to the center of the head, and the outer one is the edge of the acetabulum roof, sir. It's more than 20 degrees is good, 15 to 19 degrees is fair, and less than 15 degrees is poor. Lateral pillar classifications are herring classification. Group A, lateral pillar maintain full height with no density changes identified, sir. It has good outcome. And group B maintains more than 50% height, has poor outcome in patients with bone age of more than 6 years. Group B and C border, lateral pillar is narrowed, that is 2 to 3 mm, or poorly ossified with approximately 50% height. Group C is less than 50% of the lateral pillar is. Group C has poor outcome in all patients. Results.
You have to give pictures. Classically, there are 8 or 9 classifications in Purchase. Nobody can understand this in one go. Don't put pictures, nobody will understand. Center edge angle also, it's a lateral center edge angle. There's something also medial center edge angle in FAI. So what lateral center edge angle is, what are the lines, how it is drawn. I think it's a pointer will be better presented.
Yeah, I think most of the classifications, maybe not all are followed, but I think you should be important. It is, you have to have at least 2 classifications.
Yes. And now
Pictures always important. You must get pictures. Yes. But anyway, this is a journal club. We are only discussing about the article what we published.
Yes.
They haven't given any. They don't give any pictures because it's not.
results, 88 children who have studied, 70 are male and 18 are female, sir. And
Did
more
they mention how many were followed up?
88 patients, sir.
All 100% follow up. How many were lost to follow up?
They didn't
No
say-
follow up.
no.
Only data were collected.
Yes, sir.
That's it. Okay.
Retrospective.
No all of.
Data over 30 years, sir. From 1990 to 2010. Over 30 years, they've collected 88.
All right. Okay.
And it is more of male patients were affected, sir. And the presenting of a
So it's an audit.
yes, sir, more.
So they did not call the patients for clinical examination or anything. Only data, whatever is data is there.
The most of the patients were came around 7 to 9 years, as that is 44 patients, sir.
When was this published?
It was 2018, sir.
18.
18, sir.
Oh, about 7 years back.
Yes.
Okay.
The height of the lateral pillar of the femoral head at presentation was significantly associated with the outcomes. Of 88 children who undergone varus derotation osteotomy, 59 of the belongs to Herring's group B and 29 belongs to group C, sir. The 3 patients who had poor results of and 19 patients with fair results had restriction of abduction and internal rotation, limping and Trendelenburg gait, and limb length discrepancy of 1 to 2 centimeters is present, sir. In 66 children with good results, shortening is less than 1 centimeter was noted initially. At 6 years follow-up in 66 children who had good results, limb length discrepancy is and Trendelenburg gait was absent. Remaining 22 children who had fair and poor outcome had persistent limb length discrepancy and limping, sir. Hence, varus derotation osteotomy improves the outcome in most of the patients in Herring's group B, many children in group C.
What is good outcome according to them? You have told Moses index good, fair, and poor. So is that the criteria? What is a good result? Patients not having complication is a good result. That has to be mentioned. What is talking as a good result?
Good results, like we should see the X-rays, sir.
No, no,
Content.
what index they used?
Radiological outcome.
Yes, sir. Both functional and radiological, sir.
So what is the
Cat-
criteria? A good result means radiologically the herring should be this, Moses index should be fair, and functionally what are the criteria? Whether they have any free abduction is there, whether they
No restriction of the movements and good containment of the head in the acetabulum, sir.
that is radiological. I'm asking about functional.
No restriction of movement, you said.
Sir, Kettle classification is there, sir. Previously I mentioned.
No, no, function. Functional outcome.
Yes, sir. It's
Okay, you already mentioned about
Kettle
no
classification.
restriction, no shortening, no Trendelenburg gait. But you have to see that assessment also. What is the basis?
Yes.
But this is all data. See, all the data may not be recorded. See, the classifications. These are all retrospective, isn't it?
Yes.
And functional outcome, they mentioned, probably some may not mention. Assessment is not according to the protocol. So you don't know how many were assessed for leg length discrepancy, how many were assessed for range of movements, whatever is there, some may be absent. They have not mentioned according to that one. So probably it's not really validated data. That's important. And 2017, see, IJO that time they were desperate for papers.
Yes.
There were now I think quality has changed. Now it's difficult to publish. Similar paper if they send now, they won't publish.
Yes.
Because that time there was no papers for
Yes.
them. Everybody sending abroad. Because I am assessor. What is it called? Reviewer for Indian Journal. I know what kind of articles will get published nowadays.
Yes.
Go on.
Age of the patient at the time of presentation was also found to be significantly associated on the functional outcome of the disease, sir.
And you don't have to put so much. See, just age. Any slide will have one picture, okay? One diagram like this, 3 or 4 bullets here, 3 words.
Yes.
Then you can speak more. If so much is there, people will be put off. Any presentation, maybe 3-4 bullets here, 3-4 words here, only one sentence, 3-4 words.
Okay.
No point in writing sentences here. And one diagram here.
Okay.
Okay.
When comparatively less than 9 years, it has good and fair results. Then more than 10 to 15 years, the results were not good. Poor, sir, it was. The procedure improves the sphericity of the head by attaining containment in 66 children have good outcome and 19 children with fair outcome, sir. This is particularly true in belongs to Herring's group B. It's good procedure to attain containment in patients in the stage of fragmentation. The gender of the patient was not significantly associated with clinical outcome. So the gender of the patient did not alter the various measures of the outcome after varus derotation osteotomy. From these observations, it is clear that varus derotation improves the clinical and radiological outcome in patients who undergo surgery during the fragmentation stage of the disease. The outcome is definitely more favorable in patients belongs to Herring's group B when the surgery is done early in course of disease, that is less than 9 years. This patient also shows the Herring's classification is good prognostic indicator to predict the outcome after varus derotation osteotomy. 2 of the 88 patients had complications, infection, a deep infection, and treated parenteral antibiotics, and the implant removal was done, sir. And the secondary osteoarthritis was later managed by hip arthroplasty. Average postoperative shortening was 0.96 mm, and however most children tolerate shortening, sir. None of the patients had non-union of the osteotomy site, nor did any of these go in implant failure. Conclusion: varus derotation osteotomy is effective containment method for femoral head for patients belongs to Herring's group B. It is good procedure to attain containment in children less than 9 years of age. Gender of the patient does not alter the outcome of the varus derotation osteotomy. Trochanteric apophysiodesis reduce the risk of limping, sir.
So have you learned anything? Yes.
Yes, sir.
What is those pictures? Gone?
And good outcome seen, sir.
Their cases.
Yes, sir.
Okay, next.
It has poor outcome at 12 years of age.
So more age than.
Yes, sir.
No, go back. What is this? You know all these people?
Like Albibatis.
Everybody knows? Perthes disease named after these 3 people. Long time back. Nothing much changed. Okay. Very good. See, that's a good one. Presentation is good. You would put effort. But what happens is authenticity. Yes. Authenticity is important. You can't have, this is 2017, which is outdated. That time, I was telling, IGO was desperate for papers. And it's all retrospective study, which is not going to be used. See, have you learned anything new? We know osteotomy works very well. Have you learned anything new? What else? See, any new knowledge, it should affect your practice, isn't it? Then only you spend call, because everybody is busy nowadays and every minute is important. So have you learned anything new?
Usually in our hospital we will do open wedge osteotomy, sir. And my topic is close, sir, comparatively.
So you think closed is superior to open?
Yes, sir. Comparatively.
Why superior?
Bone contact is good in close, sir.
But what's the disadvantage?
We should incision site is way bigger than the close.
No, most important thing
Shortening is present.
Yes, they are already short.
Yes.
Nowadays, closed wedge osteotomy is not done. That was done 1990. Yes. Technology was not there.
Yes.
Now all osteotomies are open wedge.
Yes.
Because technology changed, more advantage. Most of these people, irrespective of hip, knee, anywhere,
yes,
open wedge osteotomy. You've seen open wedge osteotomy, high tibial osteotomy, distal femoral osteotomy, all open wedge, because we gain the length.
Yes.
Most of these people are shortened, so you should not shorten them more.
Further shortening.
So that's not advantage. You're not going to change your practice. So you spend so much of time. What's the new knowledge? It's important. That's why last time I told, next time onwards, you must get approval of us.
Yes.
Put in the group. What is this one? Then it's important.
No, sir.
Nothing like that.
Nothing mentioned about the vascular supply. Yes. Yes.
Just, I think that is just for the sake of publication, we have published. Nothing, no spreading of new information. Okay, next time, as we discussed, that's the idea. So, Jackson, next week, we'll take one class about level of evidence, presentation. No, you have to teach them. See, they are not able to present well means it's now our fault. We are not teaching them well. Okay, you wanted to ask something. Okay, next one, present cases. While you're answering question. X-rays, all done.
Containment of the heads. Containment of the. Yes.
We didn't show to him. You must. I think next, who is going? Vivek or Sushma, both of you present, both of you together. And topic also will decide what you choose. What is the? Last time we said about osteotomies. Osteotomy discuss. What else we can? We will end of the day in the OPD. We will decide. Both of you present. Sushma, she's here. No. We will, and you should be able to analyze. Journal club is meant to your ability to criticize, your ability to improve publication. By criticizing, you should be able to publish. The information is there. That's not important. You read so many things, but main intention of a journal club, the whole idea of introducing journal club to trainees is your ability to criticize, starting with the title to the conclusion, whether appropriate or not. And you should be able to, then only you can publish, isn't it? Nowadays, publication is very, very important. You have to publish. And you can't rely on the information of ancestors. You have to have current data.
Yes, sir. Ketral classification.
Lateral theory is there. Stolberg's is there, right? Which one you want to?
What is that?
Elizabethan, right? Elizabethan, right? But all are different things. Only thing you should know about. I mean, restrict to only one classification which is there. And the Taylor's classification is one, clinical classification is one. There are so many classifications keep on coming. Okay. Unless you know what exact etiology you do not know, pathology you do not know, keep on saying things. Years together now. 100 years we have been talking about Perthes without any solution till now. That's the problem with this.
That's what I said. Yeah. Still, since then, there is not much. The only golden principle in Perthes is containment. Whether you contain non-operatively or operatively. That decides the fate. And whatever you do, the fate most of the time is decided by the disease itself. If it presents late, no amount of surgeries or intervention will change the outcome.
Yes.
So you have to understand, and you should be able to explain to the patient that what would be the outcome, whether we treat or not.
What do you do for the 20 years patient post Perthes sequelae? You'll end up in osteoarthritis only, coxa magna or coxa breva. Ultimately has to come for total hip replacement only. That's what that has to postpone.
How was the 14-year? We did replacement. 14-year-old girl.
14 years.
You were there at that time?
No, sir.
No. Because she crippled, we postponed for 4 years. She developed severe pain, arthritis at the age of 10 or 11. And she was crippled. It's not nice to do replacement at the age of 14. But sometimes we have to do, provided they understand the outcomes or the implications, because she would need many revisions. Thesis, how much how far it's come? First years? You thought about thesis topic? Maybe one of these days. So we have to, I think, and very appropriate. Thesis selection should be very short one,